Thank you very much. Are you going to be able? Are you going to turn the lights off so it's not shining on my bald head? Well, I'm clicking. Cool. Thank you very much. Thank you very much. Thanks, Edwin. Thank you for asking me to speak. So I'm going to look at PET-CT and whole-body MR, and I'm going to tell you some of the stuff that's out there, some of the truth behind it, and hopefully some of the future directions we might be going in. I have a couple of declarations of interest. I'm a consultant to Alliance, a PET scanning service, and I have a joint grant, and I like the Oscar Wilde quote, if you can read it. Okay, there's quite a lot out there on comparing PET-CT and MR in various aspects for looking for metastases, for looking for nodal disease, comparing overall diagnostic accuracy, and whether FDG PET-CT and DWI are similar, and in what ways they're similar. And broadly speaking, although there's no very large studies, and most of them are not prospective and involve changes in patient management, performed well, probably whole-body DWI, MRI plus STIR plus GAD is probably similar to PET-CT, probably. Whether it makes a difference for each individual patient is moot, and then you need to start looking at what you're looking at and the cost of it. And is there any point in suggesting one is better than the other, or is there a way to use both to get more diagnostic information? So if we accept that PET-CT in lung cancer is the standard of care in determining surgery, is there and radical treatment, is there any point in looking at MRI to replace it? Because that's a very, very popular movement at the moment. And if that's the case, when might we do that? Oh, sorry, it's gone backwards. Okay, so what are we trying to achieve when we do additional imaging other than multi-slice CT in patients with lung cancer? And we do need to take into account when we're comparing MR and PET-CT that they're providing completely different information in relation to how they're obtaining that information. We need to think about the cost and availability, the time it takes, and is there any way at all in this rapidly changing environment we can potentially future-proof for the next 10 plus years what we're going to do in the modalities that we're going to use it, so that we can do the thing that is most important that actually PET has done, which is to put it into a patient pathway to change patient therapy. Not to say, well, we can do this, but to actually say we should do this and we will make a different treatment decision based upon it. Because that's the key bit that very many of the studies don't manage. For good reason. It's very, very, very difficult. So what are we trying to achieve when we do additional imaging in lung cancer for those undergoing radical therapy I'm talking about? And you can look in the clinical practice, we're looking at staging, we're looking at the primary tumour, nodal disease, and metastatic disease. And I've put solitary pulmonary nodule evaluation at the bottom, we'll come to that. So for a primary tumour, in terms of additional imaging, multi-slice CT has sort of almost killed the role of adding MRI for primary tumour staging. Here is a pancreas and a superior sulcus tumour, and you can see it beautifully on multi-slice with the coronal reformat, and it shows how easy it is to see in the coronal reformat compared to the actual section. The PET doesn't really add anything to the primary tumour staging, as you'd expect. The spatial resolution is poor, and MRI probably is slightly better, for superior sulcus tumours, probably slightly better, and you don't need to do DWI imaging down at the bottom with ADC maps. They add nothing at all to primary tumour staging. So I think, on the whole, apart from a little bit of MR, we can say that there is very little to add by adding additional imaging to primary tumour, the T stage. So we're really after nodal disease and metastatic disease. So I'd like to take you back to the seminal paper for PET in lung cancer, the one that actually really kicked this off around the world and enabled everybody to start getting a PET scanner with a big enough patient population, and those that are going to undergo therapy, radical therapy, the PLUS study, which was a beautifully designed study. It had 200-odd patients. It randomised them into conventional workup or conventional workup plus PET, and it followed them to whether they had a futile thoracotomy. In other words, whether they had their chest opened for no benefit, and they defined futile thoracotomy perfectly, as in there was no benefit. The patients died within a year. Actually, it was benign disease. It was inoperable, etc. So it would be as you and I would wish to design it. And what they showed, there was a 50% reduction in futile thoracotomies. So a no-brainer, actually, that you needed to have a PET before you had your chest opened, because half the time your chest would no longer be opened because of the PET. So in terms of cost efficiency, it ticked the right boxes. In terms of patient outcomes, it ticked the right boxes. And they chose that outcome perfectly. They didn't choose that it altered survival. You might think, well, it will alter survival. Well, we'll come back to that. So that's the outcome they chose. But, and it's a big but, if you look at what they picked as their definitions, are they what we would now, for futile thoracotomy and the change, are they how we now practice? So they looked at nodal disease, and you doubled the instance of detecting nodal involvement using PET. You had a 7-fold increase in metastatic disease detection, 7 to 1, 8% or so of their patients. And you had a 3-fold reduction in the number of times you operated on benign granulomas. So start thinking about it. Is that how we now practice? Well, if you look further at the detail, in those in conventional workup, only a quarter of the patients had spiral CT. Only half of them were given intravenous contrast. In other words, half the patients in their conventional workup being assessed for lung cancer for radical therapy, only half of them were given intravenous contrast. So you're not going to be able to assess the liver for a start. And we know about spiral. 10% didn't include the liver and adrenals, and they had a relatively high instance of benign granulomatous disease. It depends on where you are in the world. So we can say that that's not the current standard of imaging. And that's quite important, because if you conducted the trial now with multi-slice CT with intravenous contrast, would we have got the same result? So where is its true value, assuming that we're going to use multi-slice CT and do it well? Is it to look at nodes? Is it for metastatic disease? And is it solitary pulmonary nodule assessment? Well, there's been a huge amount done on nodal FDG PET detection of nodal involvement. I've listed some of it there, and there's been 2 meta-analyses, one on PET alone and one on PET-CT. The bottom one is worth looking at from the Journal of Thoracic Oncology, and they only took in their meta-analysis patients that had had histological confirmation of nodal involvement. And what they then changed, they analysed that data per patient or per node, or both, in their study. And what they showed is what you know, which is FDG PET is good, but it's not good enough to make a treatment decision upon it. And this has been borne out by a recent study in thorax, which I'll put my glasses on, I'll now read the bottom, and it says, those without enlarged lymph nodes and a PET-negative mediastinum, no CT enlarged lymphadenopathy and FDG negative can go to surgery. Probably. But any form of nodal enlargement, with or without PET avidity, needs to be assessed to see where there's disease in it. And that's actually how most people now practice. So you need to start wondering about what is the value of FDG PET in assessing mediastinal lymphadenopathy above that of CT detection of nodal involvement, nodal enlargement. And a lot of that is because there is now an alternative to sampling the mediastinum other than mediastinoscopy or anterior mediastinotomy, and that's this beast, EBUS, which is becoming the standard of care for assessing nodal disease, such that there's a raft of publications, there's even more than I've listed here, that effectively shows that it's performed well. It's now replacing mediastinoscopy for involvement of nodal disease. And that's been taken into account in the British Thoracic Society guidelines, the National Institute of Clinical Excellence guidelines, and the American College of Chest Physician guidelines, all recently published. And what they show, this is from NICE, but they're all similar, what they show is that the decision on whether to use PET to assess the mediastinum depends upon whether there is a CT enlarged lymphadenopathy rather than anything else, and that if you have a peripheral lesion without nodal enlargement within the mediastinum, then you don't need to sample the nodes, but any form of nodal enlargement or any central lesion, then you need to sample the mediastinum. And that's how that works out. So that means that if you look at these scans, this patient here, let's take this one up here, top left, a small peripheral lesion, there's no mediastinal nodes and no FDG PET, there's no mediastinal lymphadenopathy, straight till surgery, but all other instances, this one where there's markedly FDG avid, this one where there's nodal enlargement but it's at background, they need sampling, and this patient, when they present, can go straight to EBUS and have nodal sampling. So you start to wonder where the true value for FDG PET-CT is in assessing the mediastinum. Do you do it after do you do the scan after you've had EBUS to see if there's peripheral disease? Do you do it before to guide it? Do you not do it at all? So you need to wonder. It's not at all clear in comparison to the PLUS study, which was 12 years ago. And I just put this in because it's self-evident, but it's incredibly nicely done. In a study of almost 1,000 patients, they had a development set where they looked at nodal involvement, and they developed an algorithm. And the greatest likelihood of having an N2 node is having an N1 node, which makes perfect sense, but it's really nicely demonstrated here, and it's nice to know that actually the lung cancers are behaving properly, that they mostly go by stepwise growth. What about MR for nodal disease? Well, I've just listed some of the literature there, and obviously ECR make these slides available to you, but it looks as though it's probably as good as PET-CT, and it's not the DWI imaging that is probably of value, it's stir imaging or imaging with and without contrast, but it's probably up there or close to PET-CT. But you need to debate whether you need to do it to look at the mediastinum, because we've just discussed that actually there's a better technique for doing it. So, having thought about the mediastinum in terms of how we're going to help our patients, what about metastatic disease? Well, this is the data from the ISLAC database on lung cancer with tens and tens, and I think about 90,000 patients in it, looking at metastatic disease. And almost half the patients with lung cancer, 40% of them, have multiple metastases in multiple organs, so bone, liver, etc. After that, the commonest site of metastatic disease, single organ, is bone and then liver. Brain will come to separately in adrenal. So if you're going to pick a way of looking for metastatic disease, you want one that covers bone, liver and adrenal, Clearly, you need to scan the head, and clearly PET alone doesn't do that. So what about our detecting metastatic disease? Well, according to the literature, between 8 and almost 20% of patients that have had prospective PET-CT or PET alone have metastatic disease detected on that study. But is that correct in the current practice that we have? And I'd suggest it's not close to being correct. I'd suggest that you guys all doing multi-slice CT do it fantastically well now that we've got used to it, and it's far lower than that. And I'll just show you the issues that there are. So here's one of my mistakes. Here's a bone metastasis in the humeral head, which we picked up on PET. But actually, there it is on my diagnostic CT. So it wasn't that PET was good, it was that I was bad. And so human error plays a part, and as my colleagues that don't do PET would say, PET's easy because it just colours in badness red. The other thing is, here is a patient with a lung cancer. There they have their bone metastasis. It wasn't detected on their staging CT, but the reason it wasn't detected on their staging CT, if you see it clearly there, is that at that stage, we stopped at the bottom of the liver when we were staging lung cancer. Well, why would you do that when the commonest site of single organ metastatic disease in lung cancer is the bone, and the biggest bone that you have in your body is the pelvis, and we're choosing not to scan it? So we have now incorporated scanning the pelvis in patients with lung cancer, not solitary pulmonary nodules, to look for bone metastases. And Jean Lee, one of our fellows, is presenting this paper on the value of it, but the bottom line is that if you perform multi-slice CT completely, including the pelvis, etc., then the true yield of detecting metastatic disease on top of multi-slice CT is under 3%, around about 2.5%, which is pretty small. And just to show you, here is a patient from her study who's got a liver metastasis there, detected on PET, but actually there it is on the unenhanced liver of the PET scan. Here is a patient referred with lung cancer for staging with an adrenal metastasis, and there it looked fairly normal on the staging CT, but actually that's the size of the adrenal on the PET, on the CT component of the PET-CT, that it had grown substantially in the short period of time between the CT and the PET. So the staging CT and the staging PET. So you need to take that into account. It's not that PET's being better, it's just that if you give cancers time to grow, they grow. Okay, clearly PET does have, FDG PET does have a place. As I said, it's probably under 3%, detecting occult bone metastases with normal-looking skeletons and peritoneal and odd metastases. Okay, so I went back to the PLUS study. So just looking at this was the study in Annals, relatively recently published. It was a very large study looking at the added benefit of PET-CT compared to CT. And what's interesting is, although it wasn't appropriately powered, PET-CT had no effect on survival in the patient group. So that's quite depressing and sobering, and we may need to think that we can do slightly better. So are we doing PET-CT, have we got this wrong? And should we actually, are we doing it on the wrong patient group? Are we doing it too slowly? Are we not getting enough patients to have PET-CT? So if this was, let's pick someone you liked with a lump up there, your aunt, your wife, not your mother-in-law, and there is a left upper lobe tumour, looks like a tumour, smoker, hemoptysis, you've told her for years to stop smoking, etc. What would you want? Would you want to have your CT be discussed by a chest physician, then come to an MDT for discussion, then everyone say, well, you need an EBUS, and then, or would you want to go straight to PET-CT and cut out the middleman, cut out that, in England, it's up to 6 weeks. I know that's very different in other parts of civilized world. That's the rest of the world apart from England, probably. So would you want to go straight to PET-CT? Because then the decisions can be made. So what you might wonder is, instead of having PET-CT at the bottom of the diagnostic pathway, move it up in some patients to just after the chest X-ray. This was looked at 6 or so years ago, 8 years ago, but it was PET alone, and that study showed that actually if you put PET right up front, you have less diagnostic interventions than if you do it at the end of the pathway. And we recently published exactly a similar thing with PET-CT, and we selected patients that would be suitable for radical therapy, either surgery or radical radiotherapy, decent performance status, and a high clinical suspicion of lung cancer, including an abnormal chest X-ray. And what we showed was actually that in that patient group, you can select the patients correctly, you decrease the number of visits they have to hospital, and you decrease the time and patient anxiety, etc. And it's cost efficient. It washes its face financially. So that's something that might be considered in the future. You should certainly, as I said, you should do head CT or MR, and the guidelines suggest you should do that in patients that you're going to radically treat. We've recently looked at about to publish 250-odd patients, and they cerebral metastasis pickup rates about 2%. But the point about this slide is that you can build it in to your PET-CT study, because that patient group are patients that are pre-selected for potential radical therapy, and your technicians can, at the end of the study, just do a contrast-enhanced head CT. It takes them less than 3 minutes, and then you have a one-stop shop. You don't have to bring the patients back. You don't have to bring them back for MR, etc. So that's probably a better way of personalising it for the patients, and you don't have to do it on all the patients with suspected lung cancer. What about metastatic disease for DWI? As I said, there's a raft of literature. It looks as though it's DWI imaging that you want, and it looks as though it's broadly comparable, maybe slightly better until now, I'll say, than PET. And here's a patient of ours with a left upper lobe tumour, and that's a sternal metastasis on DWI. So we should also I'll add this before going on to where I think we are in the future. You should certainly use PET-CT in small cell lung cancer in those that you're going to potentially radically treat. And there's another meta-analysis showing that actually for small cell lung cancer, the standard of care now being chemoradiotherapy, you avert mistakes where people say that's a metastasis and it's not. You change the radiotherapy field, and you reduce the need for radiotherapy in those that have got stage 4 disease. This is a non-prospective, non-randomised study, but looked at 50-odd consecutive patients with small cell lung cancer. Shows that if you build PET into their care pathway, actually their time for survival and time to progression is improved, suggesting that it is of value. So sort of for the last 5 minutes or less, just talk about where are we going to go to help patients in the future and personalise the use of our additional imaging. Well, we will move, I think, to radiotherapy planning in lung cancer with PET-CT. It's not as easy as it is for cervical carcinoma and other areas, and the lack of availability is a problem, but there are a number of ongoing studies that I think will suggest that you can decrease toxicity and get improved results. And what people in the clinical oncologists, radiotherapists are now looking at is altering therapy during therapy with repeated imaging. So I think that will come. There will be prospective trials, or there are prospective trials in lung cancer comparing PET-CT and DWI. I think they're going up the wrong path there. I think for a variety of reasons, if you look at access to MR, in some areas it's just as tough as it is to PET because there's so much neuromusculoskeletal. And if you want to do a whole body DWI, and don't forget a whole body MR rather, it takes a decent PET scan now. You can do a whole body or skull base to upper thigh you can do in under 30 minutes. and that's going to come down. And so MR is not going to be any quicker, and I'm not sure how much cheaper it's going to be. But anyway, they're going to be out there. I think, following on from the last absolutely fantastic talk and one of the questions, there is a real place for PET-CT where you have combined perfusion CT and PET with either FDG or other traces, and I'll show you some that we're doing. There are new reconstruction algorithms out there exactly the same as there are in CT that will change detection rates. They'll change metabolic activity calculations, etc. I'll show you that. PET-MR does exist. It's very expensive. We don't have one. I'd like one if you have one. And there are new tracers. And I'll end with what I think we need to do. So here's a patient with a pulmonary nodule. It's got the number 1 beside it. It's FDG negative, but you can either do dynamic contrast enhanced CT at the same time as your PET, or you can do perfusion CT. And this one, you can see, instead of saying it's an FDG negative, I don't know what it is, you can say it's FDG negative, but it's enhanced from 27 to 93 Hounsfield units, and therefore, actually, whatever it is, it needs to come out, and that turned out to be a carcinoid. So you can do a DCE dynamic contrast enhanced CT or perfusion CT, and there's an ongoing study in that in the UK called Sputnik. This I think will change how we think about this quite a bit and what we're doing PET on. There's new iterative reconstruction methods with convergence modelling that enables you. The problem with iterative reconstruction in PET is that you get greater signal, but you get a shed loads of more noise that makes it very difficult, and they're not very nice images to look at, and there's a lot of background noise. But with changing conversion and the algorithm, you can get rid of the additional noise, and you can see here, so you can use IR up to 25, 30 times to get increased and true signal. And here is normal PET. This is how you and I look at it, and these are the new reconstruction algorithms, and you can see the change in these nodules, and that nodule went from an SUV of about 4 to an SUV of about 7.8. So it has a genuine change and probably represents metabolic activity more accurately. And it enables you, here's the same sort of thing. Here is the metastasis that was demonstrated here in the bone, normal on CT, but clearly much more visible with the new reconstruction algorithm. So I think we'll detect more metastases, which may affect patient care, and we'll be able to have a more accurate measurement of metabolic activity. We're combining, this is one manufacturer's synthesis unit where you squirt in your fluorine and you get your tracer out, FDG or F-MISO, etc. And there are now hundreds of these that are installed around the world to enable true multicentre studies finally to happen with tracers other than FDG. We're conducting, this is one of ours with F-MISO, so that's a hypoxia tracer, and you have perfusion here, and you can see that this is the F-MISO, so where it's perfused, actually it appears more hypoxic, which is quite interesting. So those kind of studies will now be happening. And I'll end with PET-MR. This is a making up PET-MR. Here is a patient who's got a left apical tumour. There's the FDG PET-CT showing the avidity activities peripheral, as you might expect. Here's the ADC, where it looks like a normal. This is an ADC map. It looks uniform, doesn't it? And here is the DWI. And if you compare the FDG avidity, you can see that they are showing you different things, for sure. And you can muck around with PowerPoint, and you can fuse and develop your own PET-MR. So I'll end by saying the studies that I think we need to conduct are like this one. So this is not published yet. It was presented just over 2 years ago, but they hadn't got the complete patient set. But what they did was that they everyone had a baseline FDG PET scan. This is small cell lung cancer being given chemotherapy. Then after their first set of chemo, they had another PET scan at day 18, and those that hadn't responded according to FDG PET, they changed the chemotherapy on. And in the abstract in the presentation, what they showed was that they were able to convert people who weren't responding to first-line chemotherapy to another patient, to another treatment, and they responded similarly to those that had first-line response. In other words, that PET enabled an appropriate treatment decision with a change of therapy, and that's what we've got to work at in the future. And I'd encourage you all to come to ST in Amsterdam. Thank you very much.